Well, good afternoon, everyone. Thank you for joining us at the Michigan Center for Rural Health Grand Rounds. My name is Renee Calkins. I'm the Education Manager here with the Michigan Center for Rural Health. And just so everyone's aware, the Michigan Center for Rural Health is a nonprofit state office of rural health. And a cornerstone of our office is to provide free education to rural healthcare providers. I'll be the facilitator of today's program, and I would like to welcome you to today's pharmacy grand rounds. I just have a few housekeeping items. This program is jointly provided by the Michigan Center for Rural Health and the Michigan State University College of Nursing for Continuing Education. This session provides 1 hour for pharmacists and pharmacy technicians, and physicians can self-claim this hour. And then I would like to introduce Adrienne Wilkeson from the Michigan State University College of Nursing to continue with the professional development information.
Thank you, Renee. So as Renee said, this activity will provide you with 1 contact hour of nursing continuing education credit, as well as the others that she mentioned. Our accreditation statement is on the slide there, and we are accredited through ANCC's Commission on Accreditation. You can go to the next slide. Thank you. So completion criteria for today is that you're participating in the learning activity by logging in, being present and engaged, and that you complete the post-session evaluation survey at the conclusion of the session as well. We do ask that if at all possible, you complete that immediately following the session. That is when the information is most fresh in your mind. And it also helps us stay on track to close out our activities in a timely manner. But if that is not possible, just know that the survey is open for another few days, and Renee sends out an email that has that in it as well. Is that right, Renee?
Yep.
Okay, so commercial and financial disclosures. No one with the ability to control content of the activity has a relevant financial relationship with an ineligible company to disclose today, and there are no commercial interests associated with today's activity to disclose either. And then next is the learning outcome. So our goal for you today is that you'll have increased knowledge of the different types of heart failure and guideline-directed medication management for that. And then the last slide we'll share at the very end when we have our QR code to the survey, and we'll also share the link to the survey in the chat at that point as well.
Thank you, Adrienne.
Thanks.
And with that, I would like to welcome Dr. Curtis Smith, a professor of pharmacy practice at Ferris State University College of Pharmacy. He received his bachelor's in pharmacy from Ferris State College and his doctor of pharmacy degree from the Medical University of South Carolina. After graduation, he completed 2 years fellowship in pharmacokinetics and pharmacodynamics at the University of Oklahoma Health Science Center, and currently is at Sparrow Hospital in Lansing, primarily focused on trauma, surgical, critical care medicine, and internal medicine. His specific interests are trauma, surgery, internal medicine, infectious diseases, pharmacokinetics, and advanced pharmacy practice experiences in internal medicine, trauma, surgical care, and to pharmacy students at Ferris State University. He is board certified and has taught at the National Certified Pharmacotherapy Specialist preparatory course for many years. He's involved in numerous organizations at the local, state, and national level. Again, Curtis, it is so great to have you here. We are so pleased. We always enjoy your time spent with us. So thank you very much.
My pleasure. Let me just share my screen. It's good to see, or to at least know that all of you are out there, maybe if I don't see you. And I hope now you can see my screen, and maybe the closed captions went away too. Well, I'll just keep talking, and hopefully you won't see those on your screen. So today I'm going to talk about heart failure, optimizing medical therapy, and we're going to go over a lot of different issues related to heart failure. Obviously, the biggest thing we're going to do is talk about drug therapy for heart failure, but obviously I need to give you some background information as well. So we'll go over the classes of medications and then talk about appropriate treatment for HFrEF and then appropriate treatment for HFpEF. As I go through recommendations, you'll notice there are numbers and letters next to recommendations, and these are based on the 2022 AHA American American College of Clinical Cardiology and American Heart Association, there we go, and the Heart Failure Society of America. So they have come up with guidelines, and within the guidelines, the recommendations are scored. So a lower number is a stronger recommendation. A 1 is stronger than a 2. And then the level is the quality of data that supports that recommendation. So A is the highest quality, then B, and then C is really no data, just sort of expert opinion. So just keep that in mind when we go over each of the recommendations. So before we get into those recommendations and how to treat heart failure, we need to go over what is heart failure and the definitions and how we classify it, the different types of heart failure, those sorts of things. So the basic definition is it's a clinical syndrome, and it's diagnosed based on clinical symptoms where there is problems with filling of the left ventricle or ejecting blood from the left ventricle. So either of those, if they're a problem, bottom line is you're not getting enough blood that is ejected into the body, and therefore you're not perfusing tissue well, and that's why we see a lot of the symptoms that we do. Now, as I mentioned, heart failure is a diagnosis, a clinical diagnosis, but there are some things that we can do to help us make that diagnosis. And one of those is natriuretic peptides. We can get a BNP. You've probably seen BNPs ordered all the time. And BNPs go up in patients with heart failure, which is somewhat of a good thing for them to go up. But it's also good for us because it's a marker that the patient has heart failure. You can see that BNPs are highly specific, not quite as sensitive. And if we look at the negative and positive predictive value, BNPs have a very high negative predictive value, meaning if they're negative, then the patient doesn't have heart failure. You can pretty much assume they don't have heart failure if the BNPs are normal. If they're positive, the positive predictive value is not quite as high. So a positive BNP does not necessarily mean that the patient has heart failure. So this is one of those labs that it's actually more helpful if it's negative, because if it's negative or normal, then we can rule out heart failure. If it's positive, then we have to look at other things. And BNPs also generally sort of correspond to a specific New York Heart Association class, which I'll go into in just a bit what those classes are. But with a lower BNP being in the lower New York Heart Association classification, and then as you go from 1 up to 4, you can see the BNP values go up. You can also use troponin as a diagnosis. You need to make sure, though, that there's nothing else that might be increasing the troponins. But if you have a persistently elevated troponin, that also gives you more information that the patient could have heart failure. Again, this is not a yes or no sort of thing with troponin. It just adds to the information maybe you got from the BNP. Now, we can also do more sophisticated tests. So you can do an echocardiogram with or without stress. And when you do the echo, you need to remember that the echo itself is not what is used to diagnose heart failure. Heart failure is still diagnosed based on clinical symptoms and some of these other things we've talked about. But the echo can give you an assessment of if there are any abnormalities in the heart. And obviously, it calculates an ejection fraction, which we'll talk about a lot, which is helpful in figuring out how best to treat the patient, and can also be diagnostic if it's a reduced ejection fraction. But an echo in and of itself is not diagnostic for heart failure. It just gives you some information about what's happening structurally within the heart. It can also give you some idea if there are elevated filling pressures. And then finally, you can do an invasive test, specifically a right heart catheterization, again, with or without stress. And that can be very helpful in diagnosing HFpEF, because by definition, HFpEF, the ejection fraction, is pretty much normal or very close to normal. And so you need to then get an idea about pressures within the left ventricle. And so a right heart cath can help you calculate pulmonary capillary wedge pressure, which is an indicator of left ventricular end diastolic pressure. In other words, the pressure in the left ventricle at the end of diastole when the left ventricle has totally filled. And then it also can give you an idea of pulmonary artery pressures, cardiac output, stroke volumes, et cetera. So we sort of went from a very non-invasive blood test through an echo, and now the most invasive test that we can do for heart failure, which is a right heart catheterization. So basically, when we're diagnosing heart failure, you start with the symptoms. That sort of triggers the, maybe this patient has heart failure sort of question. So the patient presents with signs and symptoms. You can do these very low risk, very low invasive studies. So a BNP, an EKG, a chest X-ray. That can help you. If the BNP is normal, you might be able to rule out heart failure and start looking at other things. If it's elevated, then you'll have to move on to an echo. And then, if the ejection fraction is low, then you can pretty much make the diagnosis of HFrEF. If the ejection fraction is normal, then you might have to move them to a right heart catheterization in order to fully make the diagnosis of HFpEF. Now, heart failure is an important disease state because it is extremely common. So over 6 million Americans have heart failure. That's about 2% of the population. Obviously, nowhere near something like hypertension, but still quite common in the population, and it increases as people age. So very low percent of the population has heart failure in those less than 60 years old. But as we move up into our 70s and 80s, then the percent goes up significantly. And as our population continues to age, the assumption is that these rates will continue to increase, and over the next 20 years will go up and up and up as the population gets older and older. Once diagnosed with heart failure, their mortality is about 6 to 7% per year. So about 7% of patients with heart failure every year will die. And if you're hospitalized for an acute exacerbation of heart failure, then that number goes up even more. And 1 out of 4 people who have been hospitalized for an exacerbation of heart failure will die within the next year. So mortality rates are pretty high. So as far as therapy is concerned, we want to do anything we can to decrease those rates. Signs and symptoms are listed at the bottom. I'm not going to read through all of these. I'm sure you're very familiar with them. Orthopnea, PND, ankle swelling, fatigue, other signs over here on the right, hepatomegaly, hepatojugular reflux. So peripheral edema, obviously everyone's familiar with that. So these are the signs and symptoms. These sort of really are the cornerstone of making the diagnosis, and then you can do those other things, as I mentioned, to confirm the diagnosis. All right, there's 2 primary types of heart failure. So the first is heart failure with reduced ejection fraction, or HFrEF. And that by definition means you have heart failure and your ejection fraction based on an echo is less than 40%. And basically that means that once your left ventricle is filled during diastole, the percent of the blood that's in your left ventricle at the end of diastole that is pumped out during systole is your ejection fraction. And so here we have people who are pumping out 20, 30, maybe 40% of the blood that's in their left ventricle at the end of diastole. And obviously, over time, that's not adequate, and that's why they have the symptoms that they do. The EF is calculated from an echo, and you can see, that's half, if not more, than the normal ejection fraction, which is about 2/3 or 65 to 70% of that volume that's there at the end of diastole that gets pumped out. And the problem here is that the ventricles are not contracting appropriately. And so they're usually dilated and their contractility is diminished. And because of that, you're not pumping adequate blood to the body. Now, there's 2 main types of HFrEF, ischemic cardiomyopathy and non-ischemic cardiomyopathy. So when you look at patients if you're not in cardiology, you're just looking at their history and they say they have cardiomyopathy, that means they have heart failure. And the only two types are ischemic or non-ischemic. So ischemic cardiomyopathy means that you have heart failure because you had an MI, because you had ischemia in your heart. And that accounts for 2/3 of patients with HFrEF. So the 2/3 of patients with HFrEF, the reason they have it is because they had an MI, some sort of ischemic event in the past, and that has led to remodeling and ultimately to diminished contractility of the ventricles. The other 1/3 are non-ischemic cardiomyopathy, and the primary cause of that is long-standing hypertension. So your patients who have hypertension, uncontrolled hypertension for 20, 30, 40 years, guess what happens when they get older? They get heart failure. And so that would be non-ischemic cardiomyopathy due to long-standing uncontrolled hypertension. And obviously, there are other causes of non-ischemic cardiomyopathy, which I've listed there, including drugs and alcohol and viral myocarditis, et cetera, obesity. But the main cause of non-ischemic cardiomyopathy is hypertension. So the main two causes of heart failure with reduced ejection fraction are MIs and hypertension. And that's why we want to control both of those things as much as possible, because the long-term effects of those are not good. All right. What about the other main type of heart failure? And that's heart failure with preserved ejection fraction, or HFpEF. And that is basically someone who has heart failure, but their ejection fraction is 50% or greater. So HFrEF, 40% or lower, HFpEF, 50% or greater. And this is sort of the HFpEF has sort of come along in the past 10 years as a very important part of heart failure. We used, 20, 30 years ago, everyone with heart failure was just treated like HFrEF, and HFpEF wasn't as big a thing. Now it makes up about 50%, if not more, of all heart failure patients. So if you're looking at all your heart failure patients, half are going to be HFrEF, half are going to be HFpEF. And that's why we need to know about both of them. Since HFpEF is primarily caused by long-standing hypertension, but also by obesity and AFib, that's why we're seeing a lot of much more cases of HFpEF because of the increased uncontrolled hypertension, increased obesity in our population, and that's what's leading to HFpEF. So in this case, as opposed to a diminished contractility in your ventricle, now your ventricle is stiff. And because it's stiff, it doesn't sort of relax as much when you're trying to fill it. So you have impaired filling. So during diastole, you can't get as much blood into the left ventricle. So even though you're pushing out the normal, quote unquote, amount of the normal percent of what's in your left ventricle at the end of diastole, because there's not as much there to begin with, you're getting less cardiac output, and therefore you're getting the symptoms associated with heart failure. So the reason you need to do a right heart cath to accurately diagnose HFpEF is because that tells you what the filling pressures are in the left ventricle. And people with HFpEF have elevated left ventricular filling pressures. And that's sort of the hallmark of this particular type of heart failure. Now, there has been a recent scoring system for trying to figure out the likelihood of HFpEF, and I've listed that here, the H2F HFpEF. And basically, you get points for obesity, AFib, age, antihypertensives, and then these other echo results that give you some sort of measure of filling pressures. And if your scores are really low, less than 2, 0, or 1, then it's probably you don't have HFpEF. If it's 6 or more, then the likelihood is very high. You might not even need to do any more, highly diagnostic tests. And then if you're between 2 or 5, you're probably going to have to do a right heart cath, at least an echo, to confirm the HFpEF. All right, you might have thought, well, hey, if HFrEF is 40 and lower and HFpEF is 50 and higher, what about the people in the 40s? Well, that's a third type of heart failure, HFmrEF. So heart failure with mildly reduced ejection fraction, and that's for people with ejection fraction between 41 and 49%. Not a lot of data on how to treat this patient population, but I'll talk about that a little bit when we go over treatment. And this, just like with HFpEF, requires that the patient have an increased left ventricular filling pressures. And then finally, the most recent type of heart failure is HFpEF, and those are patients who have had HFrEF, so their ejection fraction has been less than 40%, and now with treatment and good follow-up and other lifestyle changes, et cetera, their ejection fraction has gone up and is now above 40%. So you might have someone with this who had a past diagnosis of HFrEF, now their ejection fraction has improved, and then they would have HFpEF. It doesn't really change treatment. You still treat like HFrEF, even though their ejection fraction numbers now might be HFmrEF or HFpEF, but you still treat like the original HFrEF, and we'll go over those treatment recommendations in just a bit. So a little bit of background on the pathophysiology. So we have a decrease in cardiac output, either because there's less filling in HFpEF or because there's less contractility in HFrEF. And what that does is it increases the sympathetic nervous system. It increases the renin, angiotensin, aldosterone system, or RAS system. It increases vasopressin, and it also increases natriuretic peptides. These three things on the left actually are not a good thing, and it leads to problems associated with heart failure. Increasing in natriuretic peptides actually is beneficial because those peptides cause vasodilation and diuresis, which is good for the symptoms associated with heart failure. So with our drugs, we try to diminish these three things on the left, and we try to increase this one thing on the right. And so beta blockers help with increasing or decreasing the sympathetic nervous system. ACE inhibitors, ARBs, ARNIs, MRAs, mineralocorticoid receptor antagonists, help to decrease the renin system. DIG helps to increase cardiac output. Diuretics help to decrease fluid retention. And then finally, sacubitril, the neprilysin inhibitor, which is in the ARNI, is beneficial in that it increases natriuretic peptides, which helps with vasodilation and diuresis. So as we go through the recommendation, these are the drugs that are going to start popping out. Before we do that, though, just a little information on staging or classification. So the American College of Cardiology, American Heart Association has their own staging, which is a progressive type of staging. So it goes A, B, C, D, and you move from A to B to C to D, and you never go backwards. So you just move from one to the other. A is patients who are at risk for heart failure. B is patients who have symptoms of heart failure, or no symptoms, of heart failure, but structural heart disease, so sort of a pre-heart failure. C is our classic patients who have symptoms and they have demonstrate structural heart disease. That's a symptomatic heart failure patient. And then D is an advanced heart failure patient. The historical New York Heart Association classification is based on symptoms and goes from 1 to 4, 1 being no limitations in physical activity caused by the symptoms, and 4 being having heart failure symptoms at rest with no physical activity. And so in this case, again, the symptoms get worse as the number gets higher, but you can move between categories. You can go from 3 to 4 and then back to 2 with adequate therapy, et cetera. So that's why the ACC came up with their own that sort of just progresses through heart failure. So as far as treatment is concerned, in A, we want to modify risk factors, obesity, hypertension, those sorts of things. In B, we want to treat the risk in structural heart disease to prevent symptomatic heart failure. And then in C, we want to reduce symptoms, reduce morbidity, reduce mortality. And that's what we're going to focus on today, is sort of what is the drug therapy to help us reduce those things in symptomatic heart failure. But before I do that, I just want to give you an overview of treatment of stage A and B. So at-risk patients, control their blood pressure. If they have diabetes, start an SGLT2 inhibitor, which we now use in heart failure. And then all those, lifestyle things that Americans hate, but are really good for you. So physical activity, decreasing your weight, having a healthy diet, and stop smoking. Stage B is then pre-heart failure, and now you can start to use drugs, especially if they have specific indications for it. So if they don't have symptoms, but their ejection fraction is still low, start an ACE inhibitor. If they have had a history of an MI, start a statin, which they should be on anyway. Also, if they have a history of an MI, start an ACE inhibitor or an ARB if they don't tolerate an ACE inhibitor. And if they've had an MI, start a beta blocker. Again, these are all drugs that patients should be on anyway if they've had an MI, but this is just confirming that they are receiving GDMT for their MI. And then if their ejection fraction is less than 40%, not as strong a data, but you could also just consider starting a beta blocker. So starting those core treatments of heart failure early on in that pre-heart failure stage. Symptomatic, you still want to do the lifestyle changes as much as possible, and then follow the guideline-directed medical therapy, or GDMT. That's the phraseology you'll see all the time now, patient on GDMT, meaning they're getting all the guideline-directed medical therapy. And then in advanced heart failure, you want to continue to use GDMT according to whatever their diagnosis is, HFrEF or HFpEF. And then there's other, sort of end-of-life things that you can consider, like LVADs, cardiac transplant, palliative care, et cetera. Okay, this is just, I'm getting into actually pharmacology, not pharmacy, but this is just an overview of all of the HFrEF studies, clinical trials with drugs that have gone on through the years, starting in 1986 with the first trial, which was hydralazine and isosorbide, followed soon after that by the first ACE inhibitor trial in 1987. That's when the ACE inhibitors came out. And then going all the way up to the most recent years, where we're primarily focusing on the SGLT2 inhibitors and all the trials for them that have come out in the last 3 to 5 years. So I'm not going to go over all these trials, but you can see there's a hodgepodge of trials, and we moved from the ACE inhibitors and the ARBs to the beta blockers to ARNIs in the 2010s, and now we're dealing with the SGLT2 inhibitors. Okay, so let's talk about what I call the big four, or the primary drugs that you really need to focus on in patients with HFrEF. I'm going to start with HFrEF, then we'll move to HFpEF. So first are the renin-angiotensin system inhibitors. So ACE inhibitors, ARBs, ARNIs. If you're not familiar with ARNIs, and the only ARNI we have is sacubitril, which is the NI, the neprilysin inhibitor, plus valsartan, which is the ARB. That's where the AR comes from. So they do recommend, the guidelines recommend that you start with an ARNI. So an ARNI is recommended, or if it's not feasible, then an ACE inhibitor. And then if the patient can't tolerate an ACE inhibitor, an ARB. So an ARNI, that's not feasible, an ACE inhibitor. And then if that's not tolerable, an ARB. ACEs and ARBs obviously have very high economic value because they cost, less than $10 a month, very inexpensive, versus Entresto, which is the ARNI, sacubitril plus valsartan, which now costs $620 a month. Big difference between the two. Entresto is not generic yet. Now the guidelines, and I put this in quotes, the guidelines also say treatment with an ARNI instead of an ACE inhibitor provides high economic value. And you might think, how does a drug that costs $620 provide high economic value over a drug that costs $2 a month? And that's because, they've done fancy pharmacoeconomic analyses looking at more quality adjusted life years, less hospitalizations, et cetera, and ultimately decided that there was high economic value with the ARNIs, because we do know based on trials that the ARNI, it was better than the ACE inhibitor in the direct comparison of the two. However, this economic analysis was done over 5 years ago when Entresto cost $375 a month. So now over the last 5 years, the price keeps creeping up because it's getting closer and closer to becoming generic. And now the economic value might not be quite as high. I will maybe make it a moderate economic value because Entresto has just become so expensive. Based on the current cost and the clinical trial data, it costs $600,000 to save one life. Now, if you're that life, or that life is your spouse or your parent or whatever, then maybe $600,000 to save one life is, it is cheap. Or of course we're going to do that. But when you're thinking about it from a societal point of view, that can get very expensive. Now, the good thing with the ARNI is it's supposed to go generic in 2025. So in less than 2 years, there should be a generic for Entresto. The bad thing is Novartis, like every other big pharma company, is fighting that. And who knows, it might get in the courts and that might be pushed out for a number of more years after 2025 if it just keeps getting pushed down the road. So we'll have to see whether the generic comes out. When it does come out, then obviously you're going to have once again, high economic value with the ARNI. Make sure you don't combine ARNIs with ACE inhibitors because the neprilysin inhibitor and the ACE inhibitor both increase bradykinin, which increases your risk of angioedema and cough. And don't use an ACE inhibitor or an ARNI in a patient with a history of angioedema. You can use an ARB in that situation, but you shouldn't use the ACE inhibitor or the ARNI. Just some things to monitor: blood pressure, especially with Entresto or sacubitril plus valsartan, huge amount of hypotension. So patients' blood pressures can drop significantly. You have to be very careful titrating this drug. But then also with all these agents, potassium can go up. You can get bumps in your renal function or in your creatinine. When you start it, you can get a cough with the ACE inhibitors and angioedema. If the patient's creatinine does go up a little bit when you start these drugs, that's okay, as long as it's not more than 30% of the baseline creatinine. And you should keep these agents on even in people with GFRs less than 30. So their benefits, mortality benefits associated with HFrEF, you need to keep them on the drug even when their kidney function is diminished. And if they start getting hyperkalemia because their kidney function is diminished, and they're on these drugs, the recommendation is still continue the drug and deal in some way with the hyperkalemia, maybe by giving a potassium binder or something along that line. But the most important thing is every heart failure HFrEF patient should be on one of these agents, ARNI, ACE, or ARB. Every HFrEF patient should be on a beta blocker. And there are 3 beta blockers that have been proven to be efficacious in HFrEF: metoprolol succinate, so the long-acting metoprolol, carvedilol, and bisoprolol. You can choose any of those. They all have high economic value because they're all relatively inexpensive. Obviously, they can all lower heart rate and blood pressure. Some can cause depression, so watch for that. A good sort of clinical pearl is that carvedilol, which has alpha antagonism on top of beta antagonism. So it tends to lower blood pressure more. So you can switch from carvedilol to metoprolol or bisoprolol if hypotension is preventing you from titrating either the beta blocker dose up or the ACE ARB dose up or the MRA dose. So if you can't get all the drugs you need to get into the patient because too low of a blood pressure and they're on carvedilol, switch to metoprolol or bisoprolol, which have less effect on blood pressure. The opposite can be beneficial as well. If you still have someone who's hypertensive and they're on metoprolol or bisoprolol, consider switching to carvedilol, which will have more blood pressure lowering effects. And historically, like, 15 years ago, we used to stop or cut the doses in half of beta blockers when patients were admitted with acute decompensation or exacerbation of heart failure. That's no longer recommended. Keep them on the beta blocker, even if they're going through an exacerbation. Okay, the third of the big four, the third of the cornerstones of therapy is an MRA, or a mineralocorticoid receptor antagonist. Spironolactone is the one that's used most commonly, blocks aldosterone. Eplerenone could also be used as well. It's generic now, so you could use either one of those. Eplerenone does not have the side effect of gynecomastia, which I'll get to in a second, like spironolactone does. But for both of these agents, we're using small doses. And as long as their GFR is more than 30 and their potassium is less than 5, then you should be using these agents. They're one of the big four for HFrEF. High economic value. They can lower blood pressure, so watch for that. They can increase potassium. If their potassium gets too high, you need to hold the drug until it gets lower and then restart at lower doses and titrate slowly. And again, spironolactone can cause gynecomastia, and if that's the case, you can switch to eplerenone. And then finally, the fourth pillar, the fourth of the big four agents are the newest agents, so SGLT2 inhibitors, obviously more commonly used in diabetes, but now have a big role in renal dysfunction and also heart failure. So the three that have data supporting their use in heart failure are dapagliflozin, empagliflozin, and sotagliflozin. Sotagliflozin was just approved in May of this year. And the recommendations are to add it in HFrEF because they decrease hospitalization. So they don't have specific mortality benefits in heart failure, but they do help decrease hospitalization. So it's still a 1A recommendation, and it should be, one of the big fours. They are expensive. They cost in the upper $300 a month for a prescription, and so they have an intermediate economic value, not high because of their high cost, and they don't prevent mortality. And monitoring, just like you would monitor in people with diabetes. So because you're spilling glucose in the urine, there's an increased risk of UTIs, vaginal candidiasis, and necrotizing fasciitis. And they can also lower blood pressure and cause euglycemia, DKA. Renal function, you can't use them when your renal function starts to go down. Okay, the fifth drug, which is not one of the four pillars, was the combination with the original data showing mortality benefits, and it does have a role in some patients. So hydralazine plus isosorbide dinitrate. Notice the studies were done with dinitrate. A lot of people use mononitrate now, but realize the studies were done with dinitrate, which is dosing multiple times a day, 3 times a day, versus mononitrate, which is dosed once a day. However, hydralazine is dosed multiple times a day too. So, you can put the two together and it's maybe not as big of a deal to take it multiple times a day. So the guidelines recommend this combination in HFrEF patients who are New York Heart Association class 3 or 4 and self-identify as African American. So if you have a patient who self-identifies as African American, then you can use this combination. I sort of see it as an alternative to ACEs, ARBs, and ARNIs. But in the self-identified African American, you can add it on top of an ACE, ARB, or ARNI. But if you have other patients who can't tolerate ACE, ARBs, or ARNIs, then this could be an option instead, this combination. And in fact, the guidelines do recommend it as an alternative. Obviously, both these agents are generic. Even the mononitrate is generic, so it's a high economic value. Watch water retention. That is a problem with hydralazine, and obviously it lowers blood pressure. It can also cause reflex tachycardia, but all these patients should be on beta blockers anyway for the tachycardia, and most of these patients are on loop diuretics, so those two things can sort of be diminished. So there are 3 main clinical trials with this combination. As I mentioned, the first trial is the very first trial in heart failure. Patients were only on diuretics and DIG because we didn't have anything else at that point to treat patients. ACE inhibitors weren't around, beta blockers were around, but we thought they actually worsened HFrEF. And so added on top of that, there was lower mortality in the patients on this combo, 25% versus 34%. When ACE inhibitors came out, then they repeated this trial in 1991 and compared the combo to enalapril and found that enalapril was actually better than this combination. Now, the combination still was about the same as it was before, so it's still better than nothing, but the ACE inhibitor was better than this combination. Subgroup analysis have shown, however, that the mortality benefit with this combination was primarily in African Americans in the first trial. And in the second trial, there was a mortality benefit for the combination, again, primarily in African Americans. And in enalapril, the mortality benefit was primarily in white patients. So basically, that's where these recommendations come from. A repeat trial in African-American patients only was done in 2004 and again showed, and this was actually patients on standard therapy. So these patients were on beta blockers and ACE inhibitors, and they found that this combination, in addition to now what we would consider standard therapy, except for SGLT2 inhibitors, found lower mortality at 10 months. So all this information gives you an idea of potentially when to use hydralazine plus isosorbide, but still it's not one of the four main pillars, which is ACEs, ARBs or ARNIs, beta blockers, aldosterone antagonists, and SGLT2 inhibitors. Okay, one of the most important things with these drugs is not only starting them, but up titrating to target doses. So as opposed to heart failure, or hypertension, sorry, where we start a drug and then basically titrate it to blood pressure, here you want to get these people on maximum doses or target doses, which I've listed here. And there is data to show you that simply adding the drugs is not good enough. So adding the benefit you get from adding the drugs quickly goes away if you don't up titrate them to target doses. Now, the nice thing is for the SGLT2s, as you can see over here on the right, and for spironolactone and eplerenone, their target doses are basically their starting doses. And so obviously, there's no up titrating that you have to do. So people recommend start these drugs because immediately you're at a target dose. But for ACE, ARBs, or ARNIs, and for beta blockers, you can see we don't start generally at these target doses. So you need to be very concerned about making sure you're up titrating. And I have a study at the very end of the presentation which shows that the more persistent you are in up titrating, the better outcomes you have. And then this is information on number needed to treat. And so if you go over here to the right, they've sort of normalized the number needed to treat data for all the different agents. And you can see that, all of them have a relatively low number needed to treat. I do want to point out that the ARNI number needed to treat is actually versus an ACE inhibitor, so on top of an ACE inhibitor. So these are better than what you would get with the ACE or the ARB. And you can see beta blockers, spironolactone, the combination. Some are even lower than ACEs and ARNIs, but it somewhat depends on the trials too and how bad the patients were to begin with within the trials. And I do want to just point out at the very bottom here, quadruple therapy. So this is the four pillars, and ARNI, a beta blocker, MRA, that should say MRA, not mRNA, and SGLT2 inhibitor. You can see that their relative risk reduction is bigger than any single agent. So you do get additive effects as you keep adding these agents on. And the number needed to treat to prevent all-cause mortality over 24 months was only 4 when you're using the big 4 together. So keep that in mind. Your HFrEF patients, scan their drugs. They need to be on all 4. Just for time purposes, there's other potential therapies, but I'm not going to talk about them. They're in the slides if you want to look at the information, and you can go to the guidelines to see what they have to say about them. A little bit about HFmrEF and HFmpEF before I move to HFpEF. So HFmrEF, as I mentioned before, use an SGLT2 inhibitor, and then most people just recommend treat like HFrEF. So the four pillars, but especially ACE/ARB or ARNI and aldosterone antagonist. And as I mentioned before, HEF-IMPEF, if they improve, just continue the GDMT of HEF-REF to prevent a relapse back to the lower ejection fraction. Okay, what about HFpEF? Well, not a lot of data to support drug therapy in HFpEF. There's a little bit, but not a lot. We still need to control the risk factors of hypertension, obesity, and AFib. Make sure your patients are getting physical activity, and you can use diuretics for symptoms. The guidelines, and notice these recommendation numbers are all low. Keep that in mind. The guidelines recommend an SGLT2 inhibitor to decrease hospitalizations, does not improve mortality, low recommendation. Spironolactone or eplerenone to lower hospitalizations, low recommendation. An ARB in select patients, especially people with lower EFs, so those that are getting down into the 50s, consider it to, again, lower hospitalizations, low recommendations, and finally, an ARNI, especially with lower EFs as you get down into the 50s, and again, lower hospitalizations, low recommendation. So I want you to, one thing I really want you to take away from this presentation is that the data for drugs in HFpEF is really poor, not as strong, nowhere near as strong as it is for HFrEF. We still use drugs, yes, but they don't have as strong a role as they do in HFrEF. I'm going to very quickly go over the trials in general, just showing you that there's not a lot of data out there to support using drugs for HFpEF. So the first is a randomized controlled trial with an ACE inhibitor, no difference between that or placebo. And this was even with ejection fraction of 40 to 50%. So in the lower end, we would call this HFmrF at this point, but still no difference. The next two are ARB studies, one with candesartan, one with irbesartan. The one with candesartan, no difference. It did lower hospitalization, however, significantly. And that's where we get this recommendation in ARBs, potentially to help lower hospitalizations. And irbesartan, no difference. ARNI, so the Entresto or sacubitril and valsartan was studied. It was statistically close and definitely lower, but statistically not significantly different, but looking at death or hospital admission. There were lower rates, but they did not do a statistical analysis on death alone or hospitalizations alone. They were only exploratory outcomes, but the combination of death or hospital admission, no statistical difference. And then finally, I do want to point out a Swedish registry trial. So Sweden looked at all the patients in their country with HFpEF and looked at those who were treated with ACEs or ARBs and those who were not treated with ACEs or ARBs. This is retrospective. They matched their patients, but they did find a benefit with ACEs and ARBs in this registry trial. Again, be careful, retrospective, not randomized, et cetera. So they did try to match patients to make it more like a randomized trial, but still, take this with a grain of salt. But matched analysis or entire cohort, statistically different. Now the beta blocker studies, first carvedilol, no difference. The Swedes did another registry trial looking at all their HFpEF patients on beta blockers, yes or no. Again, they matched their patients and they found a lower all-cause mortality in the matched analysis and the entire cohort analysis. Now remember, the guidelines do not recommend beta blockers in HFpEF, but there is some data out there from this retrospective registry trial that they may be beneficial. Again, take with a grain of salt. A more recent registry study, this was one done in the US, but still a registry trial, retrospective. This looked at high doses of beta blockers versus placebo. All these patients had HFpEF and high heart rates, and they found that there was a significant difference in death in the beta blocker patients versus the placebo patients. Again, not in the guidelines, but some data to support the use of beta blockers. DIGE has not been shown to be beneficial in HFpEF based on a subgroup analysis of the DIGE trial. Spironolactone was first studied looking at symptoms, so I don't really like this ALDO DHF trial because it didn't look at hospitalizations and mortality, but the TopCat trial in 2014 did, and found no difference when they combined death or hospital admission, but there was a lower incidence of hospital admission when they teased that out. And so again, that's why the guidelines suggest adding spironolactone or eplerenone for people with HFpEF, because it can lower hospitalizations. Nitrates alone, not with hydralazine, but nitrates alone, no benefit. SGLT2s, empagliflozin first was studied, found that it decreased the combination of death or hospital admission, primarily driven by lower hospitalizations. So SGLT2s lower hospitalizations in HFpEF patients, not really death, but lower hospitalizations, and that's why the guidelines recommend them to lower hospitalizations. Dapagliflozin, almost the same exact results. Statistically lower death or hospitalization, but it was primarily driven by worsening heart failure or hospital admissions. There were lower deaths, but not statistically different. And just for future reference, a very recent trial looked at semaglutide. So if you want another reason to use semaglutide and try to get it for your patients, they looked at obese patients with HFpEF, and they did find an improvement in symptoms. So it was a small trial. They really weren't looking at hospital admissions and death, that sort of thing, although there were lower number of events, but it was just too small to really draw much conclusions from. But potentially we'll have GLP-1 data in HFpEF in the not too distant future. All right, I wanted to finish in these last 5 minutes just talking about some trials that have been published in the last few years that sort of answer some questions we sometimes have about treating heart failure. So I'm always looking for trials that are designed to answer a question that all of us as clinicians are constantly questioning in our patients with HFrEF or HFpEF. So the first question is, do loop diuretics have long-term outcomes? Because I'll ask my pharmacy students, okay, what drugs lower mortality in HFrEF? And invariably someone will say, oh, loop diuretics. But the answer to that is no. They have no mortality benefit. But it hadn't really been studied that well. And so some people question that maybe it might have a mortality benefit. So this is another registry trial. All the bad things, that come along with the registry trial, retrospective, not randomized, et cetera. But this was done in the US, same database, the optimized database. And they looked at patients who came in hospitalized for heart failure, and then looked at those who went home on loop diuretics versus those who didn't. And they found no difference in mortality, no difference in readmission, no difference in all-cause readmission. So the loop diuretics were not providing any benefit besides maybe some symptom benefits. However, when they did tease the data a little bit, they did find that there were significantly less readmissions in patients who had severe congestion. But the problem was the diuretics increased readmission in patients with no congestion. So I think the moral to this story is, in your hospitalized patients, if they have significant congestion, specifically rales and lower extremity edema, if they have a significant amount of that, then maybe the diuretics will be beneficial. If they don't, then you shouldn't just be throwing loop diuretics on any patient with HFrEF. You really have to choose the patient who appropriately needs them. Remember, though, the 4 main pillars of therapy. Okay, the next question is, if you need more diuresis, do you increase the dose of your loop diuretic, or do you add a thiazide? Usually we add metolazone. So you've probably seen metolazone plus Lasix or metolazone plus Bumex. So which is better, increasing the dose of loop or adding metolazone? So this study looked at that. Again, retrospective, but looked at those patients where metolazone was added, and then those patients where they just increased the loop to a high dose. And they found that adding the metolazone was not good. It increased your risk of hyponatremia, hypokalemia, worsening renal function, and all-cause mortality. However, just increasing the loop, even though it did have a risk of worsening renal function, did not cause those other things, hyponatremia, hypokalemia, or all-cause mortality. So bottom line is try to avoid adding metolazone, increase the dose of your loop instead. And finally, the last trial I want to briefly go over was a trial that actually looked at this up titration of GDMT. And this was actually, it was open label, but it was still randomized into two different groups. So these were patients who were hospitalized for an acute exacerbation of heart failure. And then in this open label trial, patients who did not have optimal doses of GDMT. So they weren't, and at this point when the trial was done, there were not SGLT2 inhibitors, but beta blockers, renin-angiotensin system inhibition, and MRA. So if they weren't on optimal doses, then they randomized them to normal or usual care. In other words, just letting the normal clinicians do whatever they wanted with the doses of the drugs, or up titrating them to those target doses, 100% of those target doses in 2 weeks after hospitalization. And the up titration group also had 4 visits in 2 months following discharge. So they had a little more follow-up as well, but basically they were seeing what happens when we push the doses to those target doses. They found, as you would expect, a higher percentage of patients who were up titrated to the target doses with each of the drug classes, and that's to be expected, as you can see there. As you could also expect, there were more adverse events in the up titration group because you're giving higher doses of drugs, but there were not a higher incidence of severe adverse reaction. And if we look at the benefits and the harm, we see a significantly lower all-cause death or heart failure readmission by 6 months. And if you tease those out, most of it was driven by less heart failure readmission. So basically what happens is if you intensify the therapy to those target doses, you have a lower amount of readmission with maybe slightly more side effects, but not significant enough to make it not worth trying to hit those target doses. So really push those target doses. So bottom line, I'm all set here, and I will take some questions now, but bottom line is, HFrEF, get those 4 pillars on SGLT2 inhibitor, MRA, a beta blocker, ACE/ARB, or ARNI, and get those doses titrated to target doses. And with HFpEF, you consider ARB or ARNI, consider SGLT2 inhibitor, consider an MRA, but really focus on those other things that are driving the HFpEF, like AFib, obesity, hypertension. All right, and I will take questions that people have, and you can put them in the chat, or Renee, maybe you can tell them, maybe they can voice their questions as well.
Yep, absolutely. Go ahead, and if you have any questions, unmute yourself. Just say who's speaking so we know who's speaking, and ask away. And if you need to just type in the chat, I will gladly read those off as well.
So I see one question. Oh, it's a good question too. So what are your thoughts on using SGLT2 inhibitors in patients with heart failure and type 1 diabetes? I would say you need to be extremely careful. I don't know that the guidelines speak to that. Honestly, they probably do, and I glossed over it at some point. But I would be really careful because of the risk of DKA, and generally we try to avoid SGLT2s. But it's a good question. I'll see if I can find any information, and I'll send it to Renee, and maybe she can send it to you, Roberta, if I find something that's more specific on that. But I would be very careful about using SGLT2s in type 1 diabetes patients. Can long-term use of beta blockers result in hypertension developing? Honestly, I can't think of. Um, sorry, that was a question that directly came to me. I can't think of a mechanism that would um, lead to that. Sometimes in patients with isolated systolic hypertension, when their vessels are stiff, and using a beta blocker is not necessarily the best thing. But the benefit of a beta blocker, if you have a known HFrEF patient, the benefit of the beta blocker would outweigh any sort of negative impact possibility that this could cause.
Well, if you have any more questions, please feel free, but I'm going to go ahead and share my screen so you guys have the evaluation. And I will also drop it in the chat. So the QR code here, and then let me throw it in the chat.
Do you need me to drop it in the chat, Renee?
Yeah, if you have it, I had copied it, but then there we go. I think I got it now.
Oh, yep, you got it.
All right, we do have another question. Is it reasonable to add Entresto to a patient with newly diagnosed reduced ejection fraction caused by a reversible event?
So are you talking like Takasubo? Let me look at the question. Nuance at AFib and low EF found on recent STEMI was I think if you're talking about, so first of all, I would look at whatever other disease state they had. So if you're talking about someone with a recent STEMI, they should be on an ACE and ARB or an ARNI. And so I would say definitely it's reasonable to add it in that particular patient, the STEMI patient, because they should be on it anyway for the MI. For the AFib patient, there's no data that supports that the drugs are beneficial in that, because they weren't the type of patient that was studied, obviously, in the trial. So I can't say that you definitely should do it. I think it's more than reasonable. I mean, a patient with AFib, highly likely that they have hypertension. And if you found a low EF, in the process of that nuance, that AFib, then why not choose a drug that also could potentially have a positive impact on heart failure and lower their blood pressure at the same time? So I think it's definitely reasonable. Do you have to use Entresto? That's a little debatable at this point. But definitely you should use one of those agents, ACE-ARB or ARNI, in either of those situations, as long as, like, the AFib patient doesn't have hypotension or some reason that you couldn't start it.
Well, thank you so much for being here. It's always super informative, and we truly appreciate your time and expertise. So again, thank you very much.
Thank you, everyone. Have a good holiday season.
You too. And if you guys, I will later this afternoon send an follow-up email with the handout, as well as the evaluation link again if you have to hop off. And we will see you next time. Thanks again.